Okay, so this is something which we are working on actively. So I have a special interest in digoxin. So Mohit asked me to speak about it. So this is something which I've done before also. So uh, I'm sorry these slides were made for a live audience, but I will not attempt to poll the panel here. But generally, when I ask these questions, people generally say B is the most common use for digoxin, so used in patients with heart failure and AF. And people have the tendency nowadays not to use digoxin in patients with HFrEF. And there is a small subset of people also who say they don't use digoxin at all. So this is, it's actually quite inexplicable if you really look at the data why this is so. The major concern really appears to be this increase in mortality, which seems to be associated with digoxin based on current literature. Now, I just want to start off with a couple of basic slides. So we all know how digoxin acts. Digoxin acts by inhibiting the sodium potassium ATPase, and it increases, for any given level of end diastolic volume, it increases stroke volume by improving contractility. And also it has an effect on the sympathetic parasympathetic balance, tilting it towards the parasympathetic system, and it also reduces heart rate and the pacemaker gradient. So all these are favorable effects that are produced by digoxin by virtue of its mechanism of action. Now, the key question appears to be that digoxin increases mortality in patients, which is why people are using it less and less. But let's look at the data critically. So this is the only randomized trial of digoxin in heart failure. So this was adequately powered, 7,700 patients. This is the DIG trial. And it found absolutely no reduction or increase in mortality. It had a perfectly neutral effect on mortality. And this is largely forgotten. Now, and also there was a tendency for reduction in mortality, which was related to heart failure specifically, although these are just secondary analysis. We can ignore them if we choose to, but the central data point remains that there was absolutely no effect on mortality. Digoxin did not increase mortality in HFrEF. So, but why has this question of increased mortality come up? So now there have been several studies, many studies, which are basically on AF patients, especially after the onset of the DOACs. There are many AF studies which actually had the opportunity to look at digoxin and outcomes in these patients. A lot of these patients were in heart failure. So if you look at, this is an example. This is basically a sub-analysis of the ROCKET study. So here again, they showed about a 20% increase in mortality after adjustment. Similarly, if you see, if you look at all the other studies that were available, remember all of these are observational data. There was a consistent 20% increase in mortality associated with digoxin. Now, the guidelines naturally could not ignore all of this, and so they are quite reticent about recommending digoxin in heart failure. Now, I think the issue here is that we are just not looking at the data properly. So I want to posit here that digoxin probably does not increase mortality. There is a definite benefit of digoxin in reducing worsening heart failure, and of course, it's an inexpensive, well-characterized drug. It's actually an orphan drug, which is why it's not being given its due right now. So what is the problem with the observational studies? Because as I showed you, the large majority of data for digoxin is from observational studies. So if you see, clearly there is a prescription bias here. Obviously, all these studies, they were not designed to look at digoxin, but patients who were sicker obviously got more digoxin. So this is a meta-analysis of all the available data on digoxin studies. And it clearly showed that patients who were older, patients who had more AF, more heart failure, more symptoms, more diuretic use, all of them received disproportionately more digoxin. Clearly, that is how physicians treat their patients. And if you look at the effect of on mortality based on all these studies. This is about 1 million patients or so. If you just look at only the randomized trials, the mortality there's no effect on mortality. It does not change mortality. But as you look at less and less adjusted, so more and more risk of bias, you actually get a very large increase in mortality. So clearly there is the issue of mortality stems basically from the bias, the prescription bias. Now, you might ask me, how can't we adjust for this bias? So everybody is adjusted in many, many ways. One of the best ways of adjusting apparently is propensity matched analysis. But I'll show you two examples. These are published in the same issue of European Heart Journal. These are based on the AFFIRM data. So one of them actually showed that digoxin worsened survival, and the other one did not show any difference. So adjustment is post hoc. There are several factors that you need to consider, and it depends on how you do them. You can never, even if you do them the best way, you cannot adjust for everything. Now, we actually did a small study. It's not a small study. It's the largest study of rheumatic heart disease. So the RHD study, in which we actually looked at, we showed the same trend. So if you do a propensity weighted analysis, the effect on mortality of digoxin actually came down towards neutral. Whereas if you just looked at the crude ORs and the crude adjusted ORs after conventional multivariable adjustment, it was still, it apparently increased mortality. So adjustment can never completely eliminate the prescription bias. The most elegant analysis evidence of this is from the DIG trial itself. So this is a very recent analysis. It was published last year. So they just looked at the people who, so in DIG, about half the patients, about 44% of the patients had been receiving digoxin prior to enrollment in the trial. So when they looked at the how these patients differed from the ones who did not receive digoxin prior to the trial, clearly the patients who had received digoxin were sicker. As you can see from all these, the presence of elevated JVP, peripheral edema, more RALs, more dyspnea, more orthopnea, things like that. So when they actually did the analysis by these patients, so patients who, so this is the overall analysis. This is the randomized analysis, and if you see that the blue ones are the effects from the randomized comparisons. Now, if you look at the people who received only the patients who received digoxin, so this is the people who were randomized to digoxin, and when they were analyzed based on whether they received digoxin prior to the trial or not, actually this replicated all the observational studies. It increased mortality by about 30%, 20%, 30%. Similarly for heart failure hospitalization. Whereas the overall analysis, the randomized comparison, reduced heart failure hospitalization. If you looked at it by the way, whether they had already been on digoxin or not prior to the trial enrollment, they actually, it appeared that digoxin increased heart failure hospitalization. So this is why adjustment can never be done completely by any statistical means, and we need randomized trials. So just to show that people can differ quite substantially in their response to digoxin, these are data from Remedy, our own data, and you'll see that if patients were in heart failure, these are rheumatic heart disease patients, there was a neutral effect on mortality. But if they had both AF and HF, so there seemed to be a trend towards reduction in mortality, whereas if they were in sinus rhythm without heart failure, giving digoxin apparently increased mortality. So these are anyway subgroup. They should be just looked at with caution, but these are just indicators. So the second question is, does digoxin reduce HF hospitalization? So this is the largest data again, DIG trial, clear reduction in hospitalization due to heart failure. And also there was a reduction in heart failure associated mortality, as I said earlier. Now, the other trials, there were a few elegant trials done in the early 90s, late 80s, which actually did digoxin withdrawal. So there are, this is from one of them, this is the Paradigm trial, where they actually showed that once you withdraw digoxin, they actually worsen. So these are all clear evidence that digoxin has a positive effect on hospitalization due to heart failure. So if you look at all the studies, all the small RCTs, which including DIG, if you look at digoxin withdrawal in these patients, there was a clear benefit of in patients on hospital cardiac failure hospitalization among patients who were not whose digoxin was not withdrawn. So this is something which we need to remember. Because there's a lack of time, so I'm just going to skip a few slides. So I'm just going to come down to the final suggestions for clinical practice. So digoxin should be used for symptomatic heart failure patients in sinus rhythm. There is no risk of increased mortality, at least from all the available data. Clearly, when there is AF and there is a need for rate control, and it can complement beta blockers, or it can be used in patients where beta blockers cannot be used. Withdrawal of digoxin in stable patients with heart failure is just not recommended. There are very good data for from randomized trials not to do this. I did not touch upon this for want of time, but all the analysis from all the randomized trials and observational studies suggest that the conventional digoxin serum levels that we were taught in medical school and which we practiced earlier on was probably a little high. So the current trend is and recommendation is that you use slightly lower levels of serum digoxin concentrations. And like I said, the most important answer, the best answer can come from RCT. So we are actually now doing an RCT of digoxin versus placebo, a national multi-center randomized trial on RHD patients. And hopefully we'll get some answers, at least which are specifically usable to our patients. Thank you.